Thanks, Justine. We can start with some introductions. Do you want to go first, Tasha?
Yeah, hi everyone. Are the slides, can everyone see the slides? Yeah, okay. So I'm Natasha Bloor, also known as Tasha. I'm a trainee clinical psychologist. I've been based at Nottingham Recovery Network for the last 6 months, and sadly tomorrow is my last day there.
Jade.
Hi, my name's Jade Buckingham. I'm a speech and language therapist working for Nottingham Recovery Network, part of Framework, and I've been with NRN now for 9 months.
Thank you. And I'm Anna. I'm a consultant clinical psychologist at NRN. So I've been supervising Tasha on her placement, and I guess we also designed the placement because of a recognition of the need to focus on brain injury. And Tasha, and you had some experience in working with people experiencing brain injury and SMD prior to starting training, and hence we kind of created the specialist placement so that we could benefit from her knowledge as well as her gaining in terms of being able to train with NRN. So I'll hand over to Tash now.
Thank you, Anna. So yeah, today we're going to talk about this pathway that we established at Nottingham Recovery Network, which was based around identifying service users who may have a brain injury or may have similar symptoms to a brain injury and cognitive impairment, and providing a pathway to provide some support to the service user, but also to key workers, working alongside those people. And this was sorry, I've got a really bad background noise of myself repeating. Anybody else hearing that?
Sorry, I've just muted the other person where it was coming from. So you're all right now.
Okay, sorry about that. Okay, so we'll get to it then. So the first sort of step of this pathway was recognising the need, and as Anna's mentioned, the need within Nottingham Recovery Network was already recognised before I came and started placement. And Anna mentioned earlier that I had a bit of background in working in brain injury, so specifically I'd been involved in a project that was inside a female prison in Eccleshall, which is like in Staffordshire, and we did a pilot program of screening people for brain injury. And what we found was there was a really high prevalence of people who had a brain injury within prison, and that project went further and it was replicated in male prisons as well. But then further than that, there was also research into homelessness and brain injury as well. And I worked in a project based in Liverpool. There was a service there called Neuro Triage, which is a service specifically set up in Liverpool to work with people who are experiencing homelessness or displacement and have got cognitive impairments caused by brain injury. So it is a recognised area of need within for the people that we support at Nottingham Recovery Network, not only through offenders of higher prevalence of brain injury, but also people who are experiencing homelessness are more sort of subjected to risk through living on the streets and various other things that come along with that lifestyle as well. So I was only based at NRN for 6 months, and in that 6 months, just under 6 months technically as well. And in that time, I delivered some staff training around introducing the staff to what brain injury is, what signs and symptoms we can see of somebody who may have a brain injury, and some advice on how we might be able to change the way that we work with somebody who has a brain injury to better support them and to make sure that they can access the help that would benefit them. So from after the staff training, I completed some assessments of service users who were accessing the service. So if a key worker was concerned about somebody's presentation, I'd receive a referral and I'd go and complete an assessment on them. And then I'm going to talk through a case example today. That is a real case. The names have been changed to protect the identity of the client who I'm talking about. We'll also cover some of the challenges that we've faced in establishing this pathway. And then I'll pass over to Jade, who's going to talk about how we can adjust our communication when working with somebody with a brain injury. And then we'll talk about some risks and recommendations as well. And just sort of the general idea that some of these adaptations that we talk about might benefit most people that we work with, not just people who had a cognitive impairment. So might be some useful stuff in there for people that might be struggling to engage with the service as it is. And then lastly, we'll finish talking about some future plans of what next and what available support, what of support will be available in the future. So as I mentioned before, the need was already recognised before I came into the service, not just through people within the service's observations and Anna's sort of consultancy knowledge, but through established research in the area as well. And it's this research isn't new either. I think the top figure of the high prevalence of brain injury in people who are homeless, with around 48% reporting an injury in comparison to 21% of a control group. That paper was from 2012. So the probably prevalence has probably changed and it probably is higher. But the reason I've sort of raised the point of that is that this has been a recognised problem for a long time, but it's an area where services struggle to get funding and support seems to be pretty thin on the ground, to be honest, in the past experiences I've had. I've always worked in a service which specifically provides the support, and then after it's hard to sort of give somebody something, a situation or a place which will continue with some support. There is a charity called Headway which does operate in Nottingham, but I'm not that sure on their sort of capacity to engage with people. I know that they do accept referrals, but I'm not that sure how many people they could see or how many referrals they could take on or anything like that. So yeah, within RNR, it is recognised that people present with additional cognitive impairments which may be related to brain injury. So staff members were seeing service users coming in, and obviously there's issues with housing, issues with mental health, sometimes issues with substances as well. And the staff at Framework are really well trained to deal with all of these issues, but it was noticed by people that there was something else that was that people were presenting with, a different sort of presentation that might not have been linked to drug or alcohol use and may not have been linked to mental health either, and that was leading to staff struggling to meet the service users' needs, so leading to poorer outcomes. So those service users tended to be the service users who may have been seen to not engage, or maybe be referred to another sort of support, but don't actually end up attending the appointment. And it's not because that person does not want to engage and doesn't want to access that support. It may be due to their cognitive impairment, which makes them less likely to be able to access that support without additional help from other staff as well. So there was a clear need that to provide staff with some training and pathway to access support in relation to working with clients with a brain injury. Because I think in that situation, even when staff members found out that a client had a brain injury, there was nowhere to really turn to ask for support for that and some extra additional advice on how to best work with that person. So I delivered 4 staff training sessions while on placement. Each session was the same session each time, but I did 4 to make sure that all of the staff had the opportunity to attend if they wanted to. We've got a really large team at Framework and lots of different sort of teams sitting inside of that. So we want to give the opportunity for people from every different team to have the ability to come and attend that session. So we offered on 4 different times, different days and things like that. So altogether, 52 staff attended those sessions, and the sessions covered recognising signs and symptoms of brain injury, what exactly a brain injury is, the difference between traumatic brain injury and acquired brain injury, something called differential diagnosis, which I will go on to in a bit more detail after, and that is in like the overlap of symptoms of various different problems that we might see in the service users that present to these services, and also some basic adjustments that could be made to make engaging with somebody who may have a brain injury more successful. So the staff were introduced to the new pathway and the referral system. We kept it really simple with this, and we thought there's no need, like with me only being there for 6 months, we felt there was no need to give out a really detailed referral form, and we accepted referrals via email, including a client's name and just a couple of sentences about what was concerning the staff member about their service user. And then we'd go from there and arrange a face-to-face conversation with the staff member to get a bit more information. So yeah, people were really able to refer into the service really easily. Some of the feedback that I received from the staff who had attended the training was that the training was really informative and useful. It was a positive start to thinking about head and brain injuries with the clients, and they felt it was great that we were developing a brain injury pathway. Somebody else said that the training itself was incredibly valuable as it made them realise that they had patients on their caseload who did have diagnosed brain injuries and no clear treatment plan. And somebody else said that since the session, they've been holding in mind the possible impact of brain injury and a lot more in creating a formulation about somebody. So it sounded like the staff really benefited from the training and felt that it was useful and went on to actually use the training in their work further down the line. So after the pathway had been introduced within the training sessions, so over those 4 weeks, I was kind of telling all the staff in those training sessions that we're now open to referrals. I suppose in between that time, there was probably just under 5 months, if that, but we received 19 referrals requesting brain injury assessments from the staff working within the service. 3 of those 19 did have established brain injuries with formal diagnoses. I thought that was really important because these service users had actually attended the service and disclosed that they'd had a brain injury. And this information was known, but it wasn't quite sure what to do with that information and whether and how that brain injury actually impacted the person. What we found when people did have formal diagnosis of brain injury, they could often say, yeah, I've had a brain injury and this is what happened, but they really struggled to sort of pinpoint what changed in them since the brain injury, what the symptoms were, because often when somebody has a brain injury, they can lose insight into what the symptoms are and what the difficulties are. So although people knew that they had these injuries, there wasn't much information to do for the key worker to make many changes to help the service user, and a real lack of knowledge and insight into their own difficulties. And then again, of those 19, 4 of the service users were identified as being at risk of alcohol-related brain injury. So obviously a really important thing to think about within these services, when people use alcohol as a coping mechanism and they've been using alcohol for a long time, the alcohol can create brain changes linked to Korsakoff's, and obviously the alcohol-related brain injury diagnosis. So we saw a few people who hadn't had a head injury per se, but the staff members were worried about the way that they were presenting and their cognitive skills as well. And of the 19, 12 presented with cognitive difficulties, but they were unsure of what caused these difficulties, or they lacked insight into the things that were challenging them on a day-to-day. So these were often people that if you ask them whether they've ever lost consciousness or whether they've had a serious injury to the head, they know that they've had a serious injury to the head, but they don't really link the problems that they've got with now their language, their memory, and their emotional regulation to that hit on the head. Maybe because they didn't receive the full package of medical treatment that they should have, or maybe that they didn't have any medical treatment at all for that injury. That was quite a common thing that came up within the pathway. So as for the support that was provided, so of the 19 referrals, I provided 18 consultation sessions with staff. So they were like the initial meet-up conversations that we were having to get some more information about the specific concerns about this person's presentation and a bit of background information about that person too, so I could build up a bit of an understanding as to maybe who the person was before the brain injury and what level of ability they had before, and then maybe the things that have changed after. And really important to think about within this particular service was that it might not be just the brain injury that's creating those changes in somebody, but it could be a mix of different things. So somebody may have had a brain injury, post that become homeless, and then started coping with alcohol. So if those things have happened since the brain injury, it's thinking about how those 3 things collectively will all be having a negative impact on that person's abilities. So from those consultation sessions, I completed 6 brain injury screenings, and we completed a mini cognitive assessment known as the mocker to get a bit of a general idea as to where the person's difficulties may lie, whether that's in memory, concentration, visual spatial skills, different areas we assessed. And then from those assessments, I wrote comprehensive reports. In those reports, it really sort of focused on the background of the person, what abilities they have, what abilities they had, and then what changes we've noticed since the person's had that injury. And then I go through and make some adjustments for future support. And when I finish those reports, I've had a joint meeting with the clients and sometimes their family and the key worker as well to make sure that everything written in the report was well understood, and that the recommendations were things that the client and the key worker agreed with. I think that was really important for me as well, knowing that my placement was only going to be 6 months. It was important that I left a report that would be useful after I'd gone, and that people understand it, and that it's basically it's workable for getting support in the future. So yeah, it was really important to go through those reports in detail. And what I did find was often some of the people, especially the ones who had established brain injuries, had many of reports and assessments completed on them in the past, but really didn't have an understanding as to what tests they'd completed or what the outcome was. So I wanted to make sure that their experience in this situation was different. So 5 of the clients actually attended some one-to-one psychoeducation sessions with myself. They were mainly based around gaining insight into what a brain injury is, and what a brain injury is, how their brain injury might affect them, and to focus on skills to compensate for any cognitive deficits and some skills that might help with emotional regulation, because a lot of people have emotional changes that can be linked to brain injury. So increased levels of like frustration, aggression, sometimes anger as well. Just like a difference in sort of the window of tolerance, if you think about it that way. So I spoke about with one of the clients how before she was a very mild-mannered and patient lady, and we were talking about having quite a wide window of tolerance. It would take quite a lot to make this lady like angry or annoyed. But since her brain injury, she was saying that the very, very slight, small things she can feel herself building a frustration to the point where she feels like she's going to lose her temper. And she noticed that these are things that she would never lose a temper about in the past. So helping her to understand that, because her sort of idea of that was that she was just worried that she was just becoming a nasty person. So it was really important to give her some understanding about that, and for her to recognise that that wasn't the case, and that things have changed, and through the brain injury, a window of tolerance had become quite a bit smaller. So it meant that she was able to tolerate less things before she was losing her temper. And this is an example that I'd like to talk about. I think I mentioned in the beginning of changing the names of the clients to protect their identity, but this is a real person's story who engaged with the pathway. So Anne was referred for screening and assessment by her key worker. So this was a person who had an established brain injury, and this was caused by burst cerebral aneurysm. So this client knew that was the case. They knew that they'd had a brain injury, and this was the cause of it. But after that, they didn't really know much else, other than things have been very different since the injury. So directly after the injury, Anne engaged in some short-term support through an outpatient neuro rehabilitation service, but then she was discharged due to not responding to a letter. So the reason I've put engaged in sort of commas is because Anne was going through a really, really difficult time at home at the time that this support was offered. So she had the brain injury, and sadly her father was terminally unwell, and he eventually did pass away. He passed away during Anne's engagement with this short-term support. So she was engaging with an occupational therapist for 6 sessions about adjusting to her brain injury, and she struggled to engage with that because obviously she was already tied into emotional situations with family. And then she did deal with the loss of her father as well, and didn't attend any other sessions after that. So she got 4 sessions, which she wasn't able to really engage with because of other things that were going on. And then she was also sent a letter asking us to go for a scan, which she doesn't think that she received. And because she didn't respond to that, she was discharged. So yeah, not an adequate amount of support available for the changes that were evident in Anne. So since the injury, Anne has experienced chronic fatigue, poor memory and attention, increased irritability and anger. She also really avoids socialising, and that's because she struggles to engage with and follow conversations. So she was saying to me that if somebody says something to her, she she tries to avoid getting into conversations because she can sometimes forget what the person said halfway through, or she can get mixed up with her words and not think about the right words that she wants to say to respond. So that leaves her feeling quite flustered and embarrassed in the moment. And because she's quite anxious about it, she struggles even more to find the words that she wants to find and forgets the things that people have said to her. So she feels quite vulnerable in social situations. So she chooses to isolate herself. But that's not what she was like before the injury either. And just to give a bit of a picture as well, so before the injury, Anne worked on a busy fruit and veg market stall where she would calculate the prices of various different items in her head, and somebody could ask for a big long list of items and she could just walk off and go and get everything. And after she suffered the burst aneurysm, she tried to go back to work, and she said that she couldn't hold any of the numbers in mind. If somebody asked her for 2 items, she'd forget the first item by the time they were saying the second one. And that just left her feeling really vulnerable and upset. Like she couldn't live the life that she'd been living, so things had to change. So before that, she was working on that market stall, and she was looking after her son full time, who also has additional needs. And she was doing quite well at that, and living independently. But since her injury, she has had to move back in with her mum for more support. Her and her son have moved in with her mum, and through that, she shared that she sometimes becomes snappy with mum, and then she feels very guilty afterwards, and that was impacting her mood as well. So you can see there from the injury, life changed a lot for Anne after that. So she went from working, living independently, to not being able to work, living with her mum, and also struggling with her temper and her mood as well, which wasn't an issue in the past for Anne. So with Anne's consent, I contacted the service that provided that support, the neurorehabilitation service, to find out what support she'd been offered and why she had been discharged as well. And then I completed a screening and assessment. So I met with Anne and her mum. So I thought it was really important to get mum involved, with mum being sort of Anne's closest person and a person who is in a way providing care. She's not a formal carer for this for Anne, but they are living together and they are sort of both supporting each other. It was important to involve mum, especially with Anne saying that a lot of the problems were around their relationship and how things have changed. And we also gained some information about the injury and current problems that Anne wasn't able to provide in our assessment. Following that, we did some psychoeducation sessions. So I focused around what brain injury is, spoke to her about what an aneurysm is and what a burst aneurysm is. So those things happened to her, but she had an idea of what this is, but I didn't feel like she really understood what had actually happened. So I did that through just doing some simple drawing, because it can be quite a complex thing to actually explain to somebody. But yeah, she found that quite helpful as well, of me drawing a picture of what an aneurysm would look like and then what the surgery actually does. We had some psychoeducation around emotional changes post-injury. I mentioned earlier, Anne was quite critical of herself, actually, about the changes in herself and how she'd called herself like a loner, and that she just doesn't like people anymore, and that she thinks she's becoming a nasty person. But she didn't really understand those changes were due to a brain injury. And then we also focused on some compensatory memory tactics, because Anne recognised that she was forgetting her sort of routine day-to-day tasks, and that was affecting her mood and her ability of like getting by her day-to-day things without having constant prompts from mum, because those constant prompts from mum were sometimes leading to her to lose her temper as well. And then we had some joint sessions where we focused on some relational changes. We helped mum understand the changes in Anne are related to her injury, because what we found from getting them both in the room was there was a lack of understanding on both sides as to what these emotional changes were about. Mum felt quite upset that Anne didn't seem as bothered about seeing family members when they came to visit. So I was able to explain how sort of communicating in a social setting when there's multiple people can be very tiring for Anne, and it's very difficult now. That helped us to have a bit more compassion about that, because I think mum's idea was that she doesn't care about seeing the family anymore because she didn't want to sit with them, and helping her to understand that, like, when she's becoming snappy, that it might be more linked to chronic fatigue, and that it might be evidence that she needs to take a bit of a break rather than actual anger towards her mum about something. And then I got Mum and Anne and the key worker in together to discuss the report and the recommendations. We spent a lot of time going through it in detail so that everybody had a clear understanding of what the brain injury was and what the symptoms were and what would be the best way to access support in the future. So I got some feedback from Anne and Mum. So the first one from Anne, she said, you were really good, helped to understand the things she struggles with. I thought I was just going into a nasty person, but I know sometimes it's because of my brain injury. You listened to me and took your time when I couldn't think of what I wanted to say. And you called me to remind me about our meetings, which helped me to remember. When you were telling me things about my brain injury, you tell me in a way I can understand. When I was seeing a neurologist, I didn't really understand what they were saying. I feel like I know a bit more about me now. Interestingly, with the comment as well about the neurologist, I did double check whether they let the service know that they didn't really understand. And she said no, she's just kind of like in that situation where she's saying when you've got a doctor and they're just telling you stuff, she just had this tendency to kind of agree and like go along with things because she felt like they were the doctor and they know everything and she doesn't really understand it. So she was just going along with things and wasn't able to say, no, I don't really understand what this is. And Anne's mum said she feels like she's got a better understanding of how Anne's aneurysm has changed the way she is. It's still hard at times, but knowing that she can't help being snappy helps me to forgive her. It's been good to have a clear explanation of how it affects Anne and some advice on what we can do to make things better. I feel like we know a lot more now, and you've gone into more detail than the neurologist did, which was more like, this is the problem, now you have to deal with it, which wasn't helpful. And then lastly, I've just got some feedback from Anne's key worker, mainly about giving Anne and her mum some time and space to discuss their relationship and the things that had changed, and also to give them some tools to communicate better with each other and to help Anne manage her sort of temper a bit better. Provided a comprehensive report outlining historical factors of brain injury, subsequent treatments, detailed the current difficulties, and also gave some advice on how to move forward with this too. And so the key worker said that the support has helped to increase awareness of brain injury and the impact of this on a physical and psychological level for the patient. I've looked at my practice and made changes to the way I communicate with the patient in some areas. So I was really pleased with that feedback, because that's kind of what I wanted to set out and do, to help Anne and her mum get a better understanding of the brain injury, to help them to sort of work on their relational problems that came from that, and to develop some helpful memory strategies too. So I felt I was really happy with that feedback. So obviously there was many challenges too, and it's important that we think about those as well. So there's many important successes and good things that came from this, but just thinking about if in the future other services want to set up a pathway. So working within Nottingham Recovery Network, we already know that non-attendance to appointments is a big problem, and probably wastes a lot of time and money within the service. And it's important to recognise that people who have got housing issues and use substances are more likely to not attend appointments. But then when we add in a brain injury term, that adds that the likeliness shoots up as well. So I kind of just used a bit of a procedure every time I was booking an appointment with somebody who we felt may have had a brain injury. So firstly, I'd contact their key worker, find out if I could meet them in a joint session first, find out how they are for attending, what the key worker already does to get that person to come in. Because what I found is most of the knowledge already sits within the people who know these people the best. And I'd always like arrange a time which suited them, because it's important with brain injury, especially with somebody who suffers fatigue, is to think about whether they're better in the morning or whether they're better in the afternoon. Because some people who rise early and feel better in the morning, by after 2 o'clock, they're really cognitively overwhelmed and may not be able to engage effectively. So I'd work with the person. I'd also remind the key worker of the appointment and make sure that the person is reminded on the day of the appointment every time, without any fail on that one, because what I found is most people will reply to a text if they aren't coming. But yeah, just notifying people, and that was a feedback I had from all of the service users, was that having a reminder for the appointment was really helpful, and without it they probably wouldn't have attended just through forgetting. Another challenge was the length of my placement. So I was only based at NRN for 6 months, but also we had about, say, maybe like a couple of weeks of me getting started, prepping the training and delivering that, and then also some winding down in between, and also my annual leave in between that. And I'm only based on placement 3 days a week. So in reality, the amount of days that were put towards this, it's been like the most of my placement. But I just think when we think about, I think it is like in some services there might be capacity for somebody to, you know, start something similar with the time and staff that are already in existence. Another challenge I mentioned briefly before was differential diagnosis. So our service users are often presenting with multiple problems which all affect cognitive abilities, and it's very difficult to know what sort of what conditions are causing what symptoms, and it's sometimes impossible to tell, especially if somebody's, say, like using alcohol, has got a mental health condition, has maybe experienced some trauma in the past, and has also got a brain injury. So it's important to sort of work with the person who is presenting at the moment, and rather than trying to distinguish what caused what. But it is important to keep that in mind too, about how different conditions may share symptoms of brain injury. Some of those symptoms may overlap, but then in most cases there is some distinct symptoms that may help to draw differences between multiple conditions which may be causing similar problems. So yeah, I've mentioned again, the other point, it was at times difficult to distinguish what conditions were causing what. So in my reports, I considered how these conditions may collectively interact and exacerbate cognitive impairments. Another challenge that I recognised, which came up quite often, sadly, was social care closing the case with people who I felt would definitely meet the needs of a social care assessment. And this, a lot of the time, was based on the person's lack of insight, which is a symptom of brain injury. So often they'd be referred to social care. Social care will go contact the person and ask them what sort of support they think they need. And that person says, I don't think I need any support. And then from that, social care was closing the case. You know, really important that we really fight the corner of like the lack of insight as well into, like, you know, if this person says that they don't need any support, that might be a sign even more so that they do need support, especially in the case of a brain injury. And so this just kind of goes into that differential diagnosis a bit more to give us an idea of how complex presentations may be. So these figures are based on the prevalence within people who are experiencing homelessness. So 48% of people experiencing homelessness might have had a brain injury, 68% ADHD, 27% PTSD, 12 to 19% autism, really high amount of personality disorder and substance use as well. So it's likely some people may have, you know, multiple of these problems going on at the same time, which can make it really difficult to draw out the differences. These other slides kind of go into that a bit more. So the separate symptoms of brain injury and ADHD, and then the shared symptoms too. Brain injury and ASD, brain injury and substance use, and then lastly is brain injury and PTSD as well. So just showing you how complicated it might become, but also to recognise that when people do have multiple problems which may have shared symptoms, it's important to think about differential diagnosis, and not just the symptoms of both of those disorders separately, but how those disorders may interact and create more complex presentations. And I was going to pass over to Jade now, if Jade's ready.
We could hear you, but we can't hear you anymore.
Okay, is that better?
Yes.
Yeah, I can't hear an echo anymore. That's good.
Brilliant.
Okay, so I'm just going to talk about some of the communication difficulties that we might see that are associated with brain injury. So how they might present, some of the risks and barriers that are caused because of the brain injury, and some ways to support these communication differences or difficulties. So 75% of individuals then who have a brain injury are thought to have some kind of communication difficulty following a brain injury. Some of them are going to be more easier to spot than others. So particularly if the difficulties related to speech. So speech disorders like dysarthria, for example, they present as slurred speech or slow speech, or the speech can be unclear. And this is because the muscles are weakened or uncoordinated as a result of the brain injury. Or there's apraxia of speech as well, and this is where the signals from the brain that coordinate the movements needed for speech are impaired or disrupted in some way, again meaning that then the speech then is difficult to understand. But a lot of the things that we'll see are more associated with language. So aphasia then, that affects how a person uses and understands language. So there's a couple of different types of aphasia. We have expressive or broca's aphasia, and that's where an individual struggles to use language. So they find it difficult to formulate sentences or find the words that they need. But their understanding of language is fine, and it remains completely intact. But then with receptive or Wernicke's aphasia, the person, they can present with having really good expressive skills. So they can talk at length, their language seems to be kind of grammatically correct, but actually their understanding is impaired. So what they say then might be completely out of context. So the answers that they give you perhaps don't actually reflect the question that they've been asked. But the most common communication difficulty following a brain injury is a cognitive communication disorder. And this is where the essential skills or executive functions that we need to communicate effectively are impaired. So these skills are things like concentration, attention, working memory, our planning skills, our impulse control, and then those social communication skills as well. So kind of knowing when it's our turn to speak in conversations, or whether we're using kind of the language that's appropriate for the context that we're in. And even things like being able to read and use facial expressions and body language too. But also it's important to note as well that, you know, communication difficulties can co-occur. So somebody could have, let's say, expressive aphasia, but they also might have cognitive communication difficulties too. Can I have the next slide, please? Okay, so how do these difficulties present? Well, they can present in many different ways. And the severity in how they present as well is going to vary. It's going to be dependent on where that brain injury occurred, and obviously the severity of that injury as well. And like I mentioned, if it's affected their speech, it's going to be much easier to spot, whereas these difficulties associated with kind of language or cognitive communication, they're going to be more hidden. So as an overview then, some of the signs that we might see. So someone might have difficulty kind of in starting off a conversation and then continuing with it. Someone might appear to have a lack of focus or concentration. So they might look like they're not interested at all, or become easily distracted by other things that are going off within the environment. They might make frequent topic changes, so they can start off having one conversation, but then quickly start talking about something completely different. We might see tangential speech, so wandering away from a conversation, providing details that aren't relevant to the topic, never quite getting to the point of the conversation or what they want to talk about. They might fill in gaps with information that isn't true, so to form a story or a series of events, but not actually know that they're doing it. So potentially kind of they call it like unintentional lying, because the information is there to complete a story, but it's not actually true. Someone might have word finding difficulties, or they might use the wrong word Sometimes people describe a word rather than say the word itself. So if someone wants to use the word cup, for example, they might say things like, oh, that thing that you drink out of, because they can't actually find the word that they need in that sentence. Also, sentences could be incomplete, or people fill sentences out, you know, with these kind of filler words, phrases, things like, oh, well, you know what I mean, or that thingy, or, you know, just to complete that sentence and make it make sense. People might use inappropriate language, and we hear inappropriate language a lot within the service, I suppose. But if that's unusual or kind of something that's not normal for them generally, then that could be a sign too. People may struggle to recall information. Maybe you've seen that person before and they can't remember anything that's been previously discussed when you've seen them before. And also people just might have a lack of insight into any communication difficulty too. So they might not know that there is a change in their communication because no one's kind of pointed it out to them before. Someone may present with inflexible thinking, so they're very kind of rigid on their viewpoints and opinions, and they can't consider other people's perspectives. And there might be a reduction in non-verbal communication skills as well, so kind of limited eye contact, maybe facial expressions don't kind of match with what they're saying or how they're acting, and their body language too. Okay, can I have the next slide, Natasha, please? Okay, so some of the risks that are associated with having a communication need then, well, ultimately, it's, you know, someone's potentially going to have a lack of choices or involvement in everyday decisions because if they're not able to express themselves clearly, how are they able to tell us exactly what they need and what they want that support to look like? It's going to limit relationships, and they can be both personal and professional. If it's really difficult to hold a conversation with somebody, or you're not confident about having conversations or joining in socially, then it's going to limit your interactions. Increased vulnerability. Again, if you struggle to understand situations, if you struggle to read someone's intentions, for example, then again, it's going to lead you more open to abuse, make you more vulnerable. And of course, if you do struggle to communicate as well and express your needs, that's going to make you feel quite low and anxious and depressed. It's going to make you potentially not want to engage if you feel like you're not being listened to or not being heard. Of course, it's going to reduce employment and housing opportunities if we can't access those services easily. And we see things like increased placement breakdowns, especially in situations perhaps where someone may be in temporary accommodation or a hostel, and they're provided with, you know, a list of rules or something, things that they have to follow, but they don't actually understand what those rules are. Nobody's kind of sat down with them and gone through that, or it hasn't been provided in an accessible way. Lower standard of healthcare, of course, if you can't actually get to the appointment, you forget the appointment, you sent a letter that you can't read about an appointment, how are you going to get there? How are you going to actually receive that help and support that you need? And then obviously the frustration that can come with that and come with these difficulties, you might see an increased use of kind of behaviour which is challenging, some mental health distress, and potentially offending behaviour as well. And I think the biggest thing really is it's staff who, if we're not considering these needs, we can be overestimating people's abilities and then kind of making an assumption about someone's abilities, and then kind of putting it down to kind of, oh, that person is just that they don't want to engage, they're not interested, and then that's going to impact ultimately on the care that we're giving those people and the support that we're giving them too. And really, you know, and this comes down to kind of like the Equality Act and the Accessible Information Standard, that we need to be making adjustments where needed. And this is to make sure, you know, that we are helping people to access the support that they need in a way that suits their individual communication needs, and in the hope that we can reduce these risks and break down any barriers in terms of accessing support. Now the next slide, Natasha, please. Okay, so practical changes that we can make then. So I've broken these down into how to support somebody's understanding, but also how to support their expression as well. But firstly, and I haven't put this on the slide, but I do think this is really important, is we should always be asking somebody. So let's ask people what they need. How can we support your communication? What can we do to make things easier for you? Again, not everybody, they might not know, they might go back to kind of that lack of insight potentially. So these are some of the things that we can do. So we can get the person's attention that we're working with first before we're asking questions or giving information. I know that kind of sounds pretty obvious, but just making sure that we're saying people's names so that they know that we're talking to them and we've got something to tell them. We can avoid jargon, so use simple language. And this is both in written and kind of spoken communication. But if there are more complex terms, and making sure that we are explaining what those terms mean. So breaking things down, and like Natasha said as well, we could draw pictures for people if that's going to be an easier way of helping someone understand the point that we're trying to get across. We should avoid sarcasm and non-literal language. The sayings that we kind of take for granted and use in our everyday language, for somebody else, they might find it really confusing, and then the meaning could be, misinterpreted by them. We should consider the environment. Can we reduce any distractions? Is there a quieter space where we can see people so that they can concentrate on the information that we're giving them? We should slow down, take our time when we're giving information. So don't rush through information, leaving pauses, leaving a gap between the information that we're giving. And then also give people time to process that information before moving on or asking another question. We should offer people regular breaks if they need it. So if they show signs of fatigue, or maybe offer shorter appointments if that's going to work better for that person because they can concentrate for that period of time. Give people key points to take away. So write things down, bullet point things, so they've got that information to take away with them, and then they can revisit it whenever they like. Provide reminders, encourage people and support people if they need the help to put appointments into their telephone, or provide a calendar, a visual wall chart where they can see exactly where appointments are and who they're with. Provide visual resources that to provide information or explain a process. Even videos as well can be really helpful. Again, the stuff like that, people can go back to it and they can look at it again and again, not relying so much on their memory. Avoid asking if someone's understood. So instead of saying, okay, did you understand that? And then them just kind of saying yes, because they want to get out of that situation and end the appointment. It's better to say things like, remind me what we've talked about today, or tell me what we've talked about. And then you're kind of getting them to summarize, and you're checking their knowledge at the same time, seeing how much they've managed to remember. And also we can provide information in alternative formats too. So if someone struggles with reading, we can make things large print, or we can use easy read. So that's information that's supported with symbols as well. Okay, next slide, Natasha, please. So lastly then, to support people to express themselves, we should, again, reduce distractions. It's really difficult to concentrate on what you want to say. There's lots of other things going off around you. So again, that's thinking of like the environment and thinking about the space that we're having conversations in. We can write down before appointments and meetings what you want to talk about. This gives, more time for the person to plan or structure essentially what they want to say. And it can also be then used to kind of guide the discussion if people go off topic. We can give gentle reminders or prompts as well to stay on topic. So if someone does wander off topic, just remind them, oh, we're talking about this right now. After we've asked a question, wait, so that person can formulate a response. We can make it clear once a topic of conversation's ended that we need to move on to something else now. That doesn't mean they can't get back and revisit it. But again, if someone's kind of going off topic, then right, okay, well, let's move on. Let's talk about something else. Again, thinking about body language and facial expressions, not about theirs, but what about ours? Are we coming across as a person that's there to listen? Do we look like we've got time for that person? It can make someone feel a lot more comfortable if you know that you're going to spend some time and you are there to kind of listen to what they've got to say, even if it might take them some time. Provide a paper and pen. If that person struggles with speech or expressing themselves, then let's give them a pen or paper to write things down, or draw a picture instead. Let's just offer people alternative ways of getting their message across to us. Provide visual resources, pictures or symbols. This can help people make kind of a choice or express a need. Think about how they're feeling, things like that, especially if they're not very good at expressing that verbally. There's lots of, there's a number of resources that can be used. One such resource is talking mats, and I think you can look this up if you Google it, but it's a really good resource in terms of helping people to express themselves, talk about their needs, which kind of takes that the pressure away of having to verbalize it or lose speech, I should say. Also, don't pretend that you've understood. If you haven't understood what somebody's told you, and never be afraid to kind of ask somebody to repeat themselves or clarify what they've said. And another thing that you can do as well is you could kind of say back to them what you have understood from what they've said, and then they can then offer more information or fill in those gaps that you've missed. And that's it.
Thanks so much.
Now
Jade.
I'm on mute. Thank you for that, Jade. So that kind of brings us to this last slide, which kind of just brings together a few of those recommendations. So allowing extra time in sessions, like Jade was saying, let the person know that you are there to listen at that moment. Like sometimes when we go in looking like we're rushed, people might not feel able to talk about things, or they might choose not to because they know it takes them a long time to get to their points. So yeah, just letting people know that you're going to allow some extra time in the session so that they can get to that point. And if somebody has got an established brain injury, it's okay to say, like, because of your brain injury, we're going to have some longer sessions that'll give you more time and space to think about the things that we're saying and give you a chance to think about what you want to say to me too. Learning about the person's strengths and interests when you're working with them, and playing to those strengths and interests too. So I think obviously when we work in this sort of work that we do, like with NRN, a lot of it can be focused on things that the service users finding difficult or problems that they've got in their lives. And just given the sort of population that we cover, well, given the people that we tend to work with, it's not often that those people will have people often talking about their strengths and showing an interest in them. So it can be a really powerful way of working with somebody too. Everybody who I've worked with who's got a brain injury and has got deficits in one area or another has got strengths in another area that you can really use. So if somebody's got strengths in their visual skills, like giving somebody more like pictorial diagrams or things in pictures would really benefit their engagement. Jade's already touched on this, but finding quiet space for conversations, it can be really hard to sort of zone into one conversation. There's a lot going on in the background for somebody who's had a brain injury. Be quite flexible on your session time and location if you can. I know we're all busy professionals, but making sure we get somebody at a time which is good for them and a location where they feel safe and secure would help them engage better. Always send reminders. I think whether somebody's got a brain injury or not, we want people to attend our appointments, and that's why we make them, rather than losing time and money. If we can, provide or suggest some resources, so diaries, calendars, wall charts. You know, even if we're suggesting like apps or free things that people could access, or even if we're just going to say, oh yeah, there's a diary, like if we can't provide that sort of thing, it's good to sometimes know that they're selling a diary for like 99p in a certain shop or something like that, which will help the person to get some resources in a way that isn't going to break the bank for them or sort of deter them from doing that. As James already said, write things down or encourage the client to keep notes if they're able to. I think always like playing to the person's strengths and abilities. So rather than doing something for somebody, let's check whether they have got the ability to do that themselves. And if they have, encourage them to do that. Simplify communication. Jade's already touched on this, confabulation. So confabulation is when somebody might unintentionally lie. So don't try and fact check a person's story. They don't mean they are not intentionally lying, but what they're saying they believe, but it's not actually the truth. So fact checking it can be quite upsetting for the person. And when it comes to disinhibition, also don't take it personally. That person has not lost has lost their ability to sometimes filter out some of the things that are popping into their head. So sometimes it might somebody might say something quite upsetting, but it's important for us to recognise, okay, if that person hadn't have had the brain injury, that might not have been something that they would have said.
Thanks, Tasha.
And then pass on to Anna. Thank you.
Thank you. So I just want to spend a few minutes really talking about where we might go from here as a service, but I guess also for everybody who's attending to think about where do you go from here as well. So we knew there was a need, that's why we created the placement, but having 3 days of Tasha's time kind of dedicated to cognitive assessments and thinking about this population is what's made this possible. I think we didn't know, although we know there's an overrepresentation of people with brain injury in homelessness and substance use services, we didn't really know what the demand for assessment would be or how realistic it would be to get people through assessments. But actually, Tasha's been very busy and unfortunately hasn't managed to get to all the referrals because they're still coming in. And I think we were talking earlier about the fact that, you know, as kind of word of mouth spreads, actually we're probably having more referrals now. Now that people have seen what the process is like, they're more likely to refer other people they're working with, or colleagues are more likely to see the benefits of those sessions. So we're going to try to think about how we kind of keep that service going as best as possible and that pathway best as possible. We've also got some kind of ongoing work with wider systems, particularly around alcohol-related brain damage, which is getting maybe more attention in terms of how we get people into kind of neurology or diagnosis. There aren't really any decent pathways or systems around the whole country. There's been a couple of exceptional areas of good practice in terms of alcohol-related brain damage assessment, diagnosis, treatment, and I think in terms of broader brain injury as well, there's very, very limited recognition of it. So when Tasha was talking about the differential diagnosis, you know, if you have somebody presenting with substance use difficulties, interpersonal problems, and emotional dysregulation, it's very likely that services will give them a diagnosis of personality disorder before they're considering brain injury. So for me, one of the things that I really want to see is that people are actually just starting to ask about brain injury, and also that it's not assumed that that's related to substances. So, you know, domestic abuse, blows to the head, but also choking, strangulation, overdoses. There's all sorts of reasons, accidents. If I think about the people that Tasha's assessed and people that I've worked with previously, there's a wide range of causes for the brain damage, and that's, you know, that's often, it might come around the peripheral stuff that goes with substance use, so being beaten up by dealers or pursued for debts, or getting into fights when disinhibited and under the influence, but also of course accidents, lots of car accidents, and things that actually predate the person's substance use quite often. So substance use can be a cause of, a consequence of brain injury, not just a cause. So I'm really wanting people to start asking the questions and thinking about whether brain injury is part of the issue. We've also managed to, while Tash was on placement, consult on the new NICE guidelines, so I'm just going to pop those in the chat. There's new NICE guidelines coming for rehabilitation for long-term neurological conditions, and that's including brain injury. And when they released the first draft of those, they essentially didn't mention homelessness or substance use almost at all, and so we've fed back lots of things about where we want people to be thinking about this population in terms of neuro rehabilitation as well. Obviously we don't know whether they'll make it through the consultation and into the final draft, but we're trying to really kind of fly the flag for homelessness and substance use in mainstream neurology and neurocognitive services as well. And then we've got a project starting that's more about the kind of intervention. So Tasha was able to talk about doing some of the psychoeducation work, but we think there's much more that could be done in terms of intervention. And we use acceptance and commitment therapy a lot within NRN, and there's a growing body of kind of evidence and practice around using that specifically around brain injury. So Tasha, if you want to just flick onto the next slide, please. So there's been a number of books published or coming, and a lot of research really around using ACT in brain injury. So why might people need that? They might need it in terms of kind of starting to understand themselves, adjust to living with a brain injury. So I think Tasha's case example was really good in terms of the impacts it was having on relationships, mood, self-understanding. Actually ACT can support a lot around that. It's not going to cure the brain injury, but it's going to help somebody potentially adjust and live the best life that they can with it. And then the book on the right, ACT for neurological conditions, so not just acquired brain injury, but things like MS, that's going to come out in January, and we've got a chapter in that that focuses specifically on the context of severe and multiple disadvantage, which hasn't really been there it's not in there so much in the other kind of books and work around ACT for brain injury. So we're going to try using it in this context in the new research project that hopefully we'll be getting up and running later this year and towards next year. And that's both about using it with the person who's experienced the brain injury, but also with staff to think about their responses. So if you flick onto the next slide, Tasha, this is an example that's in the chapter, an example kind of formulation of that you can use with the individual, but you can also use it with the staff. So thinking about what is it that you as a staff member working with this person wants to move towards with this person, like what are your values, how do you want to support them, and what experiences might get in the way of that in terms of your internal stuff that comes up. So that might be around thinking of them as lazy, or they're not being much hope for change, or all the thoughts that we can have as professionals that get in the way of us kind of doing a little bit more for somebody, or they're aggressive, or it might be kind of fear of how they'll react to things, could be all sorts of things, but recognizing them and then thinking about how you can work with those responses you might have to help yourself be more present when you're with them, be more open to the possibility of change, and actually take the action that you need to make the difference for them. So that's going to be trialled in the research project that's coming. So I think that's it for me, but just wanted to say a big thank you to both Tasha and Jade. We're lucky we get to keep Jade for at least a bit longer into next year, hopefully beyond that as well. But yeah, just really encourage everybody to go away today thinking about the people that you work with, whether you might have overlooked brain injury as a possibility, in terms of their presenting difficulties, and think about how you might use some of the information we've shared today to help you in your work with them. Thank you.
Thank you everyone for your presentations, and sorry about the technical difficulties, and thanks to Farzan for stepping in there to enable Jade to carry on with her part in it. We've only got one question actually in the Q&A box, so that was for you, Tash, but if anyone's got any questions they'd want to just pop in there now while we go through this question, that would be Great, thank you. So the first question, Tasha, it was from right at the beginning when you were speaking. It just says, within the brain injury research in prisons and the homelessness population, did the research happen to record comorbid ADHD with brain injury, please?
Not in the specific research that I was involved in, but I know it is a known sort of like a mix of conditions. So when I worked in male prisons, there was quite a high prevalence of ADHD in the clients that I worked with who had a brain injury. And some of the understanding around that was about how somebody with ADHD may be at more risk of sustaining a brain injury through impulsive behaviour and other things like that. But the research didn't directly look at the prevalence of both conditions together. But I do think there is research out there, I think, that does look at brain injury and ADHD in a more specific way.
Oh, yeah, thank you for answering that. No one's put anything else in the Q&A box, so I think that was the only question that we've had. So yeah.
Sorry, Justine, just to kind of add to that, I think part of the challenge is there's so much overlap in the symptoms. So people may well have a diagnosis of ADHD, or they might get if no one's screening for brain injury when they're assessing for ADHD, and I know I've had conversations with ADHD assessment services locally, and they don't necessarily automatically do that. So I think for me, one of the takeaway things that I'd want everybody to hold in mind is think about the presenting problems more than the diagnosis. So you're likely to have trouble with attention, concentration, etc. And whether you've got brain injury or ADHD, I think it's how do you work with those presenting difficulties. Obviously for ADHD there might be options in terms of medication, but I think if you're at a point of referring somebody for an ADHD assessment, also ask them whether they've ever had head injuries, whether they've ever been unconscious, whether they've ever had illnesses that might have kind of affected their brain in any way, because I think it's really easy. ADHD is very much at the forefront of lots of people's minds at the moment because it gets a lot of coverage. Brain injury, not so much. So I think just doing those screenings, and the brain injury and homelessness toolkit is quite helpful as well. If people haven't seen that, I'll put that in the chat. Sorry, Justine, I'm done.
That's okay. Thank you for that bit, Anna. Yeah, so we'll finish the session a bit earlier then, if that's okay with people. And yeah, thank you again to Anna and Tasha and Jay for presenting today, and for everyone for attending, and the contributions in the chat box. We will pick out some of the things that have been put in the chat box, and we'll put those in the follow-up email along with the slides and the link to the feedback form as well. As I mentioned, the feedback form QR code is on the screen, so if people have got a few minutes just to complete that, that would be really appreciated. The next sessions in this learning series are on the 16th of September, that's on executive function, and then the following ones on the 2nd of October, and that's on access to work and supporting neurodivergent people transitioning into employment. So they're available for registration now on the NCBS website. And I mentioned at the beginning around the work stream, which Amelia Draper leads on, the neurodivergence work stream. So people are interested in finding out a bit more about that. Amelia's details are on the bottom of the screen there, so feel free to email her around that. And if anyone has got anything that they would like to share in terms of facilitating a webinar in this learning series, the PDU email again is at the bottom of the screen, and we'd really appreciate everyone's or anyone's expertise to share within this learning series. So please do get in contact with us. And thanks
there's
again.
one more question, Justine.
Oh, is there?
Comes through, yeah, just quickly. I thought you might want to do it before we end.
Okay, thank you. Just bring that question out. Let's get the question, just bear with me.
It's from Amelia. It's, do you have a simple tool people can use to screen for brain injury to help practitioners ask the right questions? we can, so the tool that we use, you have to be a registered professional to use that, but what I can do is I can share something in the chat in terms of a list of questions that might be helpful, but certainly kind of the basic stuff of, have you ever been unconscious? Have you ever been without oxygen to the brain? Have you ever had any serious blows to the head? Have you ever kind of overdosed? Because any overdose or attempted strangulation or hanging, those sorts of things would be this, you know, there'd be indicators of brain injury. But we can send some questions to go out with the slides.